Great. Well, good afternoon, everyone. It's bang on 1 o'clock. So welcome to this week's Grand Round. My name is Professor Rebecca Fitzgerald. I'm from the Department of Gastroenterology, for anyone that doesn't know me. And we've got two very interesting sounding, contrasting talks this afternoon. So we're going to start off hearing from Hisham Ziauddin from the Department of Psychiatry, talking on psychosis in Usher syndrome. Just a reminder for you, we really welcome questions. Please use the chat function and I'll go through those after the talk. Thanks very much, Hisham, over to you.
Thank you very much, Rebecca. Thank you to everyone for coming for this presentation. So as you can tell from the title here, there isn't a major diagnostic reveal that's going to come in this presentation. What I'd like to do is tell you about this gentleman who has probably been the most complex case of my career so far. That could just mean that I've had a surprisingly unremarkable career. But his is a case that has multiple intersecting complexities. And what I'd like to do is try and just give you a sense of how we've managed those over the last couple of years. I'm going to depart from the normal sort of format of these presentations with just a little brief introduction about Usher syndrome for those of you who may not be familiar with it. It's the single largest cause of inherited deaf blindness and essentially a combination of sensorineural deafness that comes on relatively early in life in most of the subtypes, and then retinitis pigmentosa that comes on a bit later. It's autosomal recessive and affects about 3 to 10 out of 100,000 people. And essentially the pathophysiology is a dysfunction of the hair cells in the cochlea and the vestibular system, and then retinal dystrophy in the retinitis pigmentosa. There are 3 broad subtypes that are essentially distinguished by the age of onset of the different components and by the presence or absence of balance problems. Type 1 comes with very profound hearing loss or deafness at birth. Vision starts to deteriorate by around age 10, and because the vestibular involvement, people usually have quite significant balance problems. Type 2 is moderate to severe hearing loss at birth. The vision loss tends to come in adolescence in the early 20s. There aren't any balance problems. And type 3 is actually quite a late onset. So people start to develop hearing loss in childhood or early adulthood. And then the visual loss comes on anywhere between the 2nd and 4th decade. And these are people who are consequently diagnosed quite late, and their experience and their adjustment to the condition is very different from type 1 and type 2, where people often know quite early on that they have this condition or something that isn't quite right with their visual and auditory systems. And there are specific genes that have been identified that are, essentially encode these different subtypes. Now, that's all I'm going to actually do in the slideshow. What I'd like to do, just given what his case is like, is I'm just going to try and tell you his story. I'm going to skip over a lot of details because there's no way I can cover the full extent of his story in the 20 minutes. But what I'd like to do is begin by giving you a sense of who the person I'm talking about. So Jay, that's the name of the person whose story I'm going to tell you, is now 39. He was born into a hearing family and was quite severely deaf at birth, but grew up communicating in BSL in a family where the different members spoke with varying degrees of proficiency in BSL. And his mother, who he's particularly close to, or has been particularly close to for most of his life, is quite a proficient signer. He was a very bright young kid. His IQ tested in the 120 plus. He loved puzzles and making models. And early on, his family suspected that he might have an autistic spectrum disorder because he was quite particular about routines and had a lot of sensitivity to textures and smells. And his social communication was rather different from what one would expect of the neurotypical population. However, he was a very outgoing and sociable young man who liked meeting people and making friends and running educational events for both abled and disabled hearing and visually impaired people. If I describe him as very sociable, that may not fit in with what our usual models of people with autistic spectrum disorder would suggest, and that's more a limitation of our problems, a limitation of our models of autistic spectrum disorder. Okay, Jay has always been very outgoing. He did a bachelor's in graphic design and then went on to do a master's at ARU in illustration. He was a very accomplished artist and sculptor. He used to exhibit and sell his work himself. He was a keen sportsman, a runner, a cyclist, trained to a high degree of proficiency in the martial art of parkour, and used to train other students. And one of the things he was really passionate about was educating people about deafness, and as his vision started to deteriorate, about deaf blindness. He would go around doing talks at schools. When his vision started to deteriorate, and from initially talking about deafness and living with deafness, he started to try and give people a sense of, look, this is what deaf blindness is like. So he'd go to deaf schools, speak to children over there, ask them to try on blindfolds and see what it was like to communicate through hands-on BSL. And hands-on BSL is one of the ways that people with one of the major ways in which people with deaf blindness communicate. And this is where you hold the other person's hand and sign holding their hands. Okay, it's quite a demanding form of communication, and it's not something that even people who are BSL proficient can necessarily do without specific experience. But what Jay would do was also run sessions like these for adults, where he would arrange meetings on the village green, and he would blindfold adults and give them earplugs and get them to navigate a course using a white cane, just to give them a sense of what it was like to be deafblind. Now, as his vision started to deteriorate, a lot of these activities and aspects of his life had to fall away because he wasn't able to maintain them, because he simply didn't have the vision to sustain it. So he had to give up a lot of the sports, he had to give up a lot of the arts, but he adjusted life around those things, around those losses, and actually functioned independently for many, many years. He had a guide to help him go around, but he lived on his own. His mother lived just down the road and would pop in to help him out every day. He was actually a very active member of the Jehovah's Witnesses, who happened to have quite an active deaf and deafblind community, and were incredibly supportive to him. Now, this is the man that he used to be, and I never knew him through any of this period. The only reason I'm able to give you this sort of picture, even with this much detail of the man he used to be, is because in 2019, his mother wrote a biography. And she wrote this biography opening with a line that, I'm writing this because I want you to have a sense of the man he used to be and the man we have missed for the last 3 years. Because by 2019, Jay was in a very, very different place, and I got to know him late in 2019. But the events that led to our first meeting probably started off somewhere in about 2015, when Jay reported that he felt that something had changed and something wasn't quite right. He was very anxious about this because he was experiencing some odd sensations. And at one point, he felt very panicked when he was in a car and felt that he absolutely had to get out. And then, quite to his family's surprise, he made a journey on the train by himself because he said that God had chosen a wife for him and he had to go and meet her. This worried everyone, including him, and he was initially really trying to find out what might be happening for him. That was the first time he came into contact with our local mental health services in late 2015. And after some toing and froing, it was concluded that he was probably very depressed because his vision had deteriorated quite significantly by that point in time. And what was happening was likely part of that depressive illness. And one of the thoughts was that, this is a young man who's been deaf since birth and has now significantly lost his vision. And the depression was a very understandable reaction. And that's always something to be a bit careful about, because very often when we talk about things being understandable, we're talking about it very much from our point of view. I can understand why you'd be depressed, because if I was in your position, I'd be depressed too. that isn't necessarily very fair or kind to the people who we make those assumptions about. It looks very clear in retrospect that he was not just depressed, because a little while later, he made very clear that everything was fine. He didn't need any help. He didn't want to speak to anybody. Thank you very much. And he was discharged from our services. You've got to bear in mind that because he communicates through hands-on BSL, you can only have a conversation with Jay if you've got a BSL interpreter who can actually communicate for you. And he has to be very actively engaged in actually willing to communicate. And he wanted none of it. So early 2016, he pretty much dropped off the radar, and we didn't hear anything from him till August of that year, when he was admitted to the Jasmine Suite, which is a specialist deaf-blind psychiatric inpatient unit at Birmingham, because he had completely cut himself off from everyone in his life. He'd stopped going out. He developed a lot of preoccupations around religion, and these seemed to be a bit different from the sort of beliefs that he'd had as part of the Jehovah's Witness Church. But he'd lost about 3 stone in weight because he completely stopped eating and was transported to the Jasmine Suite on the Section 2 in an extremely emaciated state. And the photos from that time are really quite shocking to see, an incredibly gaunt young man. But he spent a month on the ward, wouldn't really talk to anybody, said there was nothing the matter, and could he please go home? And ultimately, they couldn't really do anything because it was impossible to get a sense of what was going on for him. So after a month, he was discharged home, came back home, and again fell out of follow-up. And we had really no contact with him over the next couple of years. Till 2018, he had to be taken back into hospital again because pretty much the same thing had happened. He had completely shut himself off. He'd stopped eating. He'd stopped going out. His house was an absolute mess. And the only reason we found this out was his mum, who he had stopped admitting into the house, stuck a phone on a selfie stick in through the letterbox and swiveled it around to take photographs of a house that was covered in rotting food and maggots and flies. So Jay was taken into hospital again, and he spent a year on the Jasmine Suite, the specialist deaf unit, from September 2018 to September 2019. That was an incredibly difficult admission because in that entire period, he spoke to his psychiatrist for 30 minutes in total. And if he didn't want to communicate, all he would do was this, which is, I'm not talking, you're not talking to me. They tried him on an antipsychotic, but it was always difficult to get a sense of, look, what's going on? What's happened to this young man's world? Because he just wouldn't tell you. And after several months on a treatment that seemed to make some difference, he was perhaps slightly warmer, because he had made very clear he wasn't going to take treatment, they ultimately tapered off the treatment and got in touch with me to ask if I would take over his care in Peterborough, where they were going to discharge him to a specialist deaf-blind facility under a community treatment order, which is a section of the Mental Health Act that allows you to treat people in the community and bring them into hospital if they don't comply with certain conditions or they deteriorate. So October 2019, I took over his care. He'd just been out of hospital for a year. He came in and he said he wanted nothing to do with me or anybody else in mental health services. In fact, he didn't want anything to do with anybody. He wouldn't sign his tenancy agreement. He wouldn't speak to his social worker. And he was in this facility where actually nobody knew enough hands-on BSL to communicate with him, which was fine because he didn't want to communicate with anybody. So I spent a few months trying to see, could I build up a relationship with him? Could I try and understand what was happening for him? I spoke to his family at length and ultimately managed to construct a picture that clearly over the last 3-4 years, Jay had changed significantly from the person he used to be. And he had developed a belief system in which he was, as far as we could understand, on the right-hand side of God and in direct communication with God. The world was going to end. He had some part to play in this, but he simply could not be bothered with the trivial material things of everyday life. Could everyone please stop bothering him about it? Why were they hassling him to pay his rent or pay for the taxis for his food shopping? These were things of the mortal realm that didn't concern him. He would spend his day in his flat on his own, lying in bed in communication with God. And how he used to communicate with God was with through a sign language of his own, with his right hand raised up high, in constant communication. And with people, from people who know BSL, who've seen this at length, they've concluded that there is no way that this is actually any known communicative language. This is some language of his own. Having spent 6 months trying to make some headway, I managed to get Jay to talk to me for 3 minutes via an interpreter who he'd known for many years. And in those 3 minutes, he told me that he was with God. He was all right. Please stop bothering me. You're the devil. Can you please go away? So one thing that was very clear was that he had clearly changed quite dramatically from who he used to be. Very early on in his time with us, his mother suffered a serious MI, and it was looking like things were really quite touch and go. But when we went to see him to tell him about this, his response was, "Why are you bothering me with this?" And he shut the door. Now, that kind of emotional disconnection is actually one of the very common symptoms of psychosis, and that relates to a sort of disturbance of emotional processing. So he had so cut himself off from everyone in his life that he hasn't spoken to his mother since August 2018 to date. And in fact, the only person he would speak to is his sister, and he'll see her about 10 minutes, open with, "Why are you here?" And 10 minutes later, "Thank you, you can go now. I don't want to see you anymore." So in February of 2020, I decided actually this wasn't working. I was going to recall him into hospital, give him a trial of treatment, because he'd only had one trial of treatment. I'd enough evidence to say that he was unwell. And it didn't seem reasonable that I could just let him continue with his life like this. However, at that point, COVID hit, and I couldn't get him into hospital because it seemed too risky to take him out of the safe environment he was in into an acute psychiatric hospital. So through COVID, that decision got delayed and delayed and delayed. And I was feeling increasingly stuck that I was really making no difference to his life. He didn't seem bothered. He didn't seem to be suffering. His family were in complete anguish about the son they had lost. So feeling very stuck with this, I took this to my CPD group, and among my CPD group members, our head of department, Professor Tamsin Ford. And this is one of these fortuitous stories about knowing people who know people. Tamsin's husband is a psychologist who works in deaf services. They put me in touch with a psychologist who's deafblind herself, Dr. Joanne Atkinson at UCL, who gave me some very helpful advice and then put me in touch with somebody else at the Birmingham Deaf Mental Health Services, who told me that, look, you're trying to do a lot for this young man with the Mental Health Act, trying to get him into hospital. But even if you do that, you're only going to be able to make a small difference to some bits of his life, his mental illness, if that does improve. But perhaps you could think about using the Mental Capacity Act to see if you could just improve his general quality of life. If you could put in some arrangements we can arrange for somebody to take care of his finances, to make sure that his tenancy is signed, to make sure that he gets the sort of support that he needs. Because if you're going to go entirely on what he consents to, he has got nothing because he wants nothing, but he's entitled to a lot more. And then I took this to Tony Holland, who's our emeritus professor of psychiatry here, who was one of the architects of the MCA, who helped me out with figuring out how to use this case to help this young man and his family. And we managed to put in place a framework to at least ensure the rest of his life was looked after. But we're still left with this position of he's still unwell, and there's nothing that we seem to be able to do to shift it. So I took this finally back to the Deaf Mental Health Services, spoke to the team in London because the team in Birmingham had had no luck with him, and put it to them, could we try and take this man back into hospital? It was already 4 or 5 years into his illness. The longer people are untreated, the worse their prognosis is likely to be. But could we give it a try? Because the options we're facing here are either we leave things as they are till the next crisis happens, whenever it happens, and we just help his family grieve for the son that they've lost. Or do we give it one more shot to see, is there any chance we can make things better than this? And very fortunately, they agreed to help. There then came the task of actually taking him to hospital. And while most of you may be familiar with the Mental Health Act, it's one thing to be able to have the legal power to take somebody into hospital. It's another thing altogether to get a deaf-blind man into an ambulance he doesn't want to go into, and trying to make it as atraumatic as possible for him. But we succeeded. We got him in. He's been on the Bluebell ward for the last 2 or 3 months in London. He's been started on an antipsychotic, and things have started to shift. He's warmer. He's now speaking to the psychiatrist on the ward. He spent an hour with his sister a couple of weeks ago, and he's now engaging and talking to people. It's become very clear that he does have a psychotic illness, because when he had to sign a few forms, he signed them all as God, not in his name. But things are looking encouraging after years of really a relentless deterioration and impoverishment of his life. So I will draw the story to a close there. What I wanted to give you was really a sense of the numerous intersecting aspects of trying to look after somebody who doesn't want to be looked after, doesn't want to communicate, and at every point having to do things requires us to actually go against his expressed wishes, and how we balance the various needs and values there and hold some hope that actually life could be better. Because I was left in the position where if we don't do something now, possibly I'm resigning this young man to basically spending the next 30, 40 years of his life in his room, speaking to nobody else, in communication with God. I will stop there and leave some time for questions. Thank you very much for listening.
Thank you, Hisham. It's really a quite remarkable story, and quite a welcome change actually to sit and listen to that exposition without the slides. So can I just ask you a question to start off, and we've got questions coming through on the chat. So I just wonder, with the benefit of hindsight, whether there's anything you would have done differently.
So I think with the benefit of hindsight, the only thing that we could have possibly done differently, and I think this is something that we failed on, is that when we couldn't get access to what was happening in this young man's world, we really should have put in a bit more to construct what his world had been and what his world had become, just using the information from his family. Right. Now, that can often be very difficult, because when you're trying to preserve people's autonomy and they say, I don't want you to talk to anybody, it's incredibly hard. And you tread this fine line between, I can't tell you anything about him, but if you can tell me stuff about him, I'll try and use it, because he's given me no permission to share. He can't deny me permission to hear.
Thank you. So there's a question here. Would you consider that there's been a contribution from an extended form of Charles Bonnet syndrome, extended due to him being deaf and blind?
No, so actually he doesn't have any visual phenomena at all as part of his illness, as far as we know. Again, he won't really tell us this. So I don't think there's that. It is an important question, because one of the things to sort of assess here is, look, is this something that's happened that's integral to the ushers? The literature on this is incredibly sparse. It's mainly case reports and some suggestion that, yes, there may be an overrepresentation of psychosis. Is some of this because of the dual sensory impairment, which does put people at risk of psychosis?
Thanks. So question from Tamsin Ford. How do you establish a rapport with someone who only needs to sit on their hands to stop any opportunity for communication?
Yes, with great difficulty is the answer. And I think how this has happened at any point has been where there have been disruptions to his control over the routine, he's willing to talk to people and say, tell me what's going on. And I think what's happened through the admission at various points is that there have been these disruptions where he's wanted to communicate, even if that's just purely instrumental. Tell me where I am, tell me why I'm going there. He's been willing to communicate, and those have been the openings. But till then, we've really struggled.
And a question from Christopher Old. How do you assess this man's capacity, given the need to treat him against his expressed will?
Yeah, so that's a whole sort of discussion in itself, but you can sort of work through, your key pillars of capacity. But his ability to take in information, he absolutely refused to take in information. His ability to weigh up information, what we had to draw on was all the sort of secondary evidence that he was not able to take in information, that he was not able to weigh up information to make the decisions he needed, based on the decisions he either failed to make or the few decisions that he did make. But yeah, this was an incredibly complex one. And ultimately, where there was doubt, we sort of erred on the side of some beneficence, because what we were asking to do without his consent was to ensure that he was looked after, not to treat his mental illness. So that his rent was paid, that his food would be taken care of, that his tenancy was assured.
Okay, that's a useful distinction. And a follow-up from Tamzin, wondering what you think about the possible ASC diagnosis now.
Yes, so the ASC diagnosis now, I think, seems a lot clearer, and we managed to, again, piece together some bits of information, because it so happened that the community consultant for the London team had assessed him back in 2013 when he was at university and wanted an assessment to support his learning needs. And he concluded at that point, on the balance of probabilities, I think he probably does have an autistic spectrum condition. And so it looks like we've got enough there to say that. Of course, we've never been able to do, and we probably will never be able to do the kind of assessment we'll need to really nail that down.
And what do you think the longer term outlook is?
So I think as is often the case with people who've had kind of long untreated psychotic illnesses, the longer term outlook depends entirely on how well can you get them. And that was really what I wanted to push for here. We had no idea how well he could be. I'm encouraged by what's happened so far, but I think if we can get him well enough to be able to communicate with people and connect with people, even somewhere near the way he used to, he could have a much richer life. And I'm hoping he'll want a much richer life, because he certainly did have one before.
Yeah. I think, unless there are any further questions, now's your moment. Okay. I'm sorry we can't give you an audible round of applause, but thank you very much for an excellent presentation, and really not the kind of thing I think we discuss very often in the grand round, but very instructive. Thank you very much, Hisham.
Thank you.
So I'm going to turn it over now to Owen McKinney from the Department of Medicine. This is a sort of interdisciplinary presentation, but he's presenting on behalf of the team, which includes Professor Mahela Vandershah and Evgeny Savelyev from Department of Applied Maths and Theoretical Physics, as well as Dr. Ari Erkol from Department of Anesthesia, but Owen will give the entire presentation. And the title, I should say, a very clever title, Learning to Make the Right Choice. Thank you very much.
Can you see my my screen as a whole screen?
Yeah, perfect.
Perfect, great, thanks very much. Yeah, so I'm presenting this on the behalf of a group of people predominantly from the newly formed Cambridge Centre for AI in Medicine, and this is one example of something that's going on at the moment. Someone's raised their hand already. Can you all definitely hear? I'm going to assume you can.
Yeah, all good.
One of the things that's relevant to this is that there's an ongoing series of presentations from Mahela's lab in the Centre for AI, and that includes one this afternoon. So what I'm showing now can be seen in more detail with more background depth and a roundtable discussion afterwards later on this afternoon, and that's an open invitation. So there's a Zoom link for that at the bottom here, and I can see if Vicky can circulate that afterwards. So if people are interested, they can tune into this later. And this is a regular repeating series, which there are 10 previous iterations of, which are available online And this will be an ongoing feature as well, and it's looking at different applications of AI in medicine, different aspects of it. So straight into the cases, and these are going to look apparently banal, especially in the context of what we just heard, but the importance of these cases and why they've been selected will become apparent later. These are cases from intensive care, and the question may seem a bit odd and irrelevant. You can see the cases here. We've got two patients who have many similarities. It'll become clear why later, for which, from my perspective at least, there wouldn't be any immediate burning indication to throw antibiotics at them. But what we're interested in here is whether the use of antibiotic in either of these contexts would improve their outcomes. And the specific outcomes here is whether either of these two patients would be more likely to come off a ventilator if they were given antibiotics. And the reason for that context will become clear a bit later on. So what we're using these cases to discuss really is how we know what treatments we should use in medicine, and it basically goes right down to the core of evidence-based medicine. And of course, randomized clinical trials are what we base evidence-based decisions upon. But whilst they're the gold standard, they're not perfect. What we do in randomized trials is we have two groups. We have a different treatment per group, for example, and we looked for a grouped mean treatment effect between those two groups of individuals, and we look to see if there's a shift in average effect. But what we then do as clinicians is we take that information and try and parse that so that we can use it on an individual patient, the person who's actually sitting in front of us. And often, because randomized trials are restricted to specific populations with inclusion and exclusion criteria, often we try and extrapolate beyond the confines of what the RCT has actually shown. That's part of the scale of being a clinician, I guess. But RCTs are also expensive, they're time consuming, they only typically use a single intervention, and they compare group mean effects. They don't give us individual information about how that given intervention might influence the person sitting in front of us. And I'm using the recovery study as an example here because they showed what was a very high profile but fairly modest effect of dexamethasone that has unquestionably been clinically important. But they went on to show with a subgroup analysis how that might be most important for only a subgroup of patients. And you see on the right here what each group in a randomized trial actually represents. It represents a spectrum of individual effects, and there might be a subgroup of people for whom that treatment is particularly important. And if we suspect who that subgroup is in advance, we can have an a priori predefined subgroup analysis, like those on ventilators or those without oxygen, in this case for recovery. And we can just define that up front, do a post hoc analysis, and have a secondary endpoint looking at a subgroup. But sometimes we don't know what the characteristics of the individuals who might benefit most from an intervention might be. So basically, treatment effects are heterogeneous within trials, and trials are the gold standard way of doing it. But individual effects are the way in which we have to apply them. And there's an increasing ability to use electronic health record data and use machine learning methods to try and learn from large volume electronic health record data to estimate what an individual treatment effect for the specific individual who's sitting in front of you might be. And I'm going to describe an application of that in a context where clinical trials really struggle to go. There are places where clinical trials simply don't fare particularly well. In heterogeneous contexts like the intensive care unit is a good example of that. Extensive comorbidities in populations with complex backgrounds like the elderly is another good example. So these are places where RCTs don't fare particularly well, and where these sort of approaches may be most applicable or have most to offer. An example here of an example cancer patient, and they have a history up to the point where the current time is where you're having to make a treatment decision. They may have had a series of treatments before, they may have responded to them, they may have not have responded to them, may have partially responded to them. So all of that longitudinal history is something that you as a clinician would take into account as you decide whether a treatment is going to benefit your patient. And as a clinician, we effectively take the health records, we parse them through our brains, and we estimate the likely outcomes with and without treatment, and then decide whether or not we should give treatment. And this is something that increasingly causal inference models that are a machine learning method that can apply learning methods to large volume health record data and estimate what are called counterfactual trajectories. So what they try and effectively do is say, given everything that's happened up to this point, is this individual patient likely to respond to this intervention at this time point or not. So they try and estimate what the future looks like with treatment and without treatment. And clearly that can then be used as a clinical decision support tool where that information can be factored into whether or not you should actually be giving the treatment. So in brief, in terms of how this actually works, much more information on this later if you want to tune in, but in essence, what the model here is trying to do is it's using an encoder system, which is a series of recurrent neural networks to take all of the historical information from a given patient, and it's doing this iteratively over many thousands of patients in a health record database, and it relies upon many thousand records in order to be able to do this. It's taking all of that background health record information and it's reducing it to learn a representation of an individual patient. So it's learning what that individual patient looks like as a function of all of the many traits that it's measuring. So say 100 or more different traits, longitudinal measurements in the ITU, all of the different CRP, white count, blood tests, all of the different baseline demographic features as well. That all gets boiled down into a representation of an individual patient. What we then do is use a sequence-to-sequence architecture of recurrent neural networks, which is a bit like what Google Translate does or natural language processing algorithms do in order to translate from one language into another. What we're trying to do here is analogous in the sense that it's trying to take the historical information and predict what should come next, but it's trying to do that under counterfactual scenarios with and without treatment, having learned what the likely treatment effect is likely to be from the training population. The important difference here is that this approach has used something called domain adversarial training, which allows us to account for all of the time-dependent confounders that exist in health record data. In other words, in all of the population who we're looking at and all the health records, the people who have been treated or haven't been treated will have differences. There will be confounders between those groups. Some of them will be time-dependent. Treatment will be given at different times, for example. And this gets around that by using this approach called domain adversarial training, which basically learns to ignore the confounding influences, to summarize what is a complex approach. And what this basically allows us to do is to use these approaches to decide not just how we should treat, in other words, at a given time point for a given individual's history, and this is done on an individual basis. We can decide whether we should use a particular intervention, and if we do give a particular intervention at this time point, what are the likely outcomes? And that can support that decision. But we can also iteratively use it to decide when we should intervene. So should I give the treatment now or should I give it next month? And I can predict what the future would be like under those different circumstances and consequently decide whether now is the right time for the treatment or not. And obviously that can be modified to decide when we should stop treatments as well. Should I stop it now or should I stop it next month or the month afterwards? So there are different contexts in which these individualized treatment estimates could operate. The one difference with the method I'm describing here that's been developed in Mehaina's lab is that it's not a black box system where you've no idea how and why it's making the prediction. It's actually an interpretable form of individual treatment effect estimation. So where we see a predicted difference in outcome with a given treatment, as is exemplified on the left there, we can use a different form of adversarial training to understand what clinical traits that were learned by the model in the first place are important and underpin the fact that there is a treatment effect estimated. So to go back to the recovery example, if we didn't know that patients on a ventilator or not receiving oxygen are likely to have different responses to dexamethasone, if we applied this individual treatment effect method, we would be able to learn that those are different populations that will respond to this treatment differently. So it can tell you who to treat, when to treat, or when to stop treatment, and also what the rationale or what the hidden reasons for those different effects are. So can it work? And that's what I want to demonstrate quickly, going back to the original cases. And this, the data I'm showing comes from the MIMIC dataset, which is a publicly available set of about 23,000 training records from the intensive care unit. The model here has been trained on about 23,000 records, and it's been independently tested on a separate set of 600. So the case examples I'm showing you are drawn non-randomly, as you'll hear, from a set of 600 case records, estimating the individual treatment effect for those records, where those 600 have never been part of the training process. So the model's never seen those in the first place. So the first one as a simplistic example, this is a 38-year-old with hypertrophic cardiomyopathy who came in and he looked septic. He was febrile, he had a raised white count, and I think we would have estimated that he's likely to benefit from antibiotics, and he may be able to get off a ventilator more quickly if he gets antibiotics. And just to introduce how this model works, you see at the top left and the top right, I've pulled off static images for the antibiotic use in this individual over time, over the course of his ITU stay. 1 and 0 are antibiotic on and off, the ventilator 1 and 0 on and off. And on the bottom row there, you've got his longitudinal features for temperature and his white count longitudinally as well. And when we feed in this individual's results at time 0, so we don't know what's going to happen in the future at this point, we could predict at the time that he enters ITU whether giving antibiotics daily, which is treatment plan 1, or giving no antibiotic is likely to impact on his outcome. And perhaps unsurprisingly for this guy, there's a large predicted impact on his outcome. And outcome here is restricted to ventilator dependence. So there's one specific intervention, antibiotics or not, and there's one specific outcome, and in this case, it's ventilator independence. However, this can be applied perhaps more usefully to contexts where there's a bit more equipoise, where it's not quite clear whether you should give treatment or not. So these cases I've selected non-randomly. So they're selected to be the 2 most similar cases in the data set. They're most similar to each other. So we have one who's a 59-year-old with a similar background to the other, 176, 159. Both were afebrile. One had a slight increase in his white count, having been admitted after a fracture. The other didn't, and was admitted postoperatively after a thoracic aneurysm. And the question would be, in this context, should we be giving antibiotics to either of them, and will that impact on their outcome, given everything that the model has learned from the training data set of tens of thousands of records? And again, to show this first individual, he got antibiotics from the start, stayed on a ventilator, then came off. We're trying to make a prediction of whether we should treat at time 0, at the time that he actually enters ITU. Neither were febrile at that point, neither had a particularly elevated white count, and there was estimated to be a treatment benefit of giving antibiotic, and he did get antibiotic. However, perhaps more revealingly, if we look at his friend, who's the closest match to him, there was clear clinical uncertainty about what should be done with antibiotics. In this case, he did have them perioperatively for the first day, but then those were stopped for the subsequent week, and then they had to go back on again. He remained on a ventilator throughout, and whilst he didn't have a raised white count or temperature to start with, he quickly developed one over the subsequent 7 days. Now, we apply this model on day 0 when he enters ITU, so the model is not aware of everything that happens outside of the red boxes here. That all happens subsequently. We're sort of getting a privileged view of what was going to happen next. We would have estimated a strong impact of giving antibiotic, and with about a week in advance of what actually happened, we would have predicted that he should have continued antibiotic, and that would have helped him come off a ventilator earlier. However, if we move, and what you can do, as I say, is decide when treatment should be given as well. If we move that treatment window forward and make subsequent predictions for every day of his ITU stay, in the green box, we're taking into account all data for the first 5 days of his ITU admission. Actually, the estimated treatment effect is gone by the time that he actually gets the antibiotic. So consistent with the idea that early antibiotics can make a difference in sepsis, before any of the obvious septic parameters that we would use to guide clinical treatment were available, or sorry, before those had risen and suggested that sepsis was brewing, there was an indication from the algorithm here that trouble was coming and that antibiotics would be helpful. To give one further case example, this is a 65-year-old hypertension, hypothyroid chap who was admitted after a stroke. Again, on the day of admission, he was afebrile, didn't have a rise in his white count, and there was no obvious clinical indication for him to have antibiotics. And again, you see over the first week of his stay, he didn't have them, but then quickly developed a need for antibiotic and went on to a ventilator. And you can see from his temperature and white count traces that those having been normal on admission rapidly rose as well. And you can see from our day 0 individualized treatment effect estimation, he did appear to have a stronger chance of going on to a ventilator if he didn't have antibiotic, and a higher chance of staying off it if he didn't. And if we look at the time series of prediction on a daily basis, so this is the sort of prediction of the treatment benefit of antibiotic benefit on the outcome here, which is ventilator independence. You can see that there's an early strong benefit. That benefit is preserved throughout. So on a daily basis, the information that a clinician in ITU would be getting would be that treatment is likely to benefit this patient, but by going by his temperature, white count, CRP, that wasn't started till day 7, by which time again the estimated benefit of the intervention is gone. So it's possible that by providing this information, it could shape early clinical decisions and allow us to make individualized treatment decisions or support those treatment decisions. It's not trying to replace the clinician, but it's trying to use learning from large historical data sets to try and support decisions in future patients for whose data has not been seen, such as these haven't been. But feature importance is another way that we can understand more about the cohort. So what I'm showing here is just for some of the cases, or the cases that I've outlined. If we actually look at the clinical features that were supporting those estimated individualized treatment effects, you've got a heat map here with importance being the bright yellow and no importance being the black. Now, included in the clinical data set here are CRP, white count, temperature, and all of the sort of parameters that we would typically use as clinicians to estimate whether someone's septic or not. Those aren't the key parameters that seem to be influencing whether a treatment effect of antibiotic therapy is present here. There are actually different features, in particular to do with inspiratory pressures for people who are on ventilators for their PEEP. And those seem to be the features that are suggestive of a need or benefit for antibiotics before those other features develop. So we can start to learn what the stratification of our population is like and what features most associate with benefit, and therefore perhaps start to understand a bit more about how and where that intervention is best deployed. So what we're really talking about here is where and how this sort of approach might fit into clinical practice. And clearly it can work because the information is given on an individual basis. It could work as a clinical decision support tool. It could learn on large volume health record data, such as is available for most of the UK, with millions of records currently available, in which we're now trying to process through the centre for different interventions and different endpoints. It's also feasible to use this in the context, or in fact, it has most to offer in contexts where clinical trials traditionally can't go. And that includes contexts that are very heterogeneous, like the intensive care unit, but also, as I mentioned, for elderly populations with high levels of comorbidity. What I should have pointed out is that while I've given case examples from the MIMIC cohort where clinical decisions could be impacted by providing this information, this has been run for prediction, at least, across the entire MIMIC cohort. You're seeing the error estimates for prediction of clinical outcome, which are very strong across the entire MIMIC data set. What we can't do, obviously, is estimate the accuracy of the treatment effects, because in the cohort, we only see one treatment decision per individual. Each individual either gets the treatment or they don't. You don't get to see the counterfactual scenario because it never happens. So one question is how that sort of treatment effect can be brought into clinical practice, and whether in fact randomized trials of this as a strategy would be necessary to demonstrate that application of this as a clinical support tool can improve outcomes. And it doesn't have to be in the context of antibiotics and ventilator dependence. That's just one simple example, because the data is available through the MIMIC data set. This could be applied in essentially any context. A couple of key caveats to mention that are perhaps obvious include that the health record data that we're using has to have some clinical equipoise around the decision. If everyone is always given given a certain treatment and they're never not given it, you clearly can't learn counterfactual scenarios from that data. And if there aren't enough circumstances where people are given the treatment, then similarly, you can't learn from that. And the amount of error associated with the estimate is also proportional both to the number of steps ahead that you're trying to estimate. So the further into the future you try and estimate, the harder it becomes. And if you're looking at counterfactual recurrent treatment scenarios, where I'm trying to say what happens if I give treatment A, then B, then C, that's harder than just saying what if I give treatment A or not at one time point. The degree of confounding variables that actually are associated with the treatment effect also influences the error of the method. What this has been rolled into is what is now a live online app where you can actually access the mimic data set and play with it. So the screenshots I've shown you are static examples from that live data set. So Evgeny has got this working where you can go through, you can change the patient history duration, you can change the treatment intervention that you want to look at, the timing of it. You can look at a different horizon over which you want to look at the treatment outcome. So it gives an example of how people can actually play with the data in real time and see how that might work and how it might be applied as a decision support tool in practice. So that will be exemplified more in the Revolutionizing Healthcare series, which was the thing I advertised at the start, which will be happening this afternoon if anyone's more interested in this, and specifically the application of AI and ML approaches to longitudinal time series data and individualized treatment effects. So I'll just finish by saying that much of the work I'm describing comes from Mihaela's lab with the people, the work attributed in the publications and the conference proceedings that are described in the slides here. Thanks very much. I've zoomed through very quickly, probably too quickly, but that leaves time for questions.
Brilliant. Thank you very much, Owen. So we do have a few minutes for questions. So if I can start off, I mean, you mentioned what the next steps might take. You described it in a fairly theoretical manner. So what in practice do you plan to do to take this kind of decision support tool to the next step? Are you thinking about doing a randomized trial, and what context would you start off as a kind of proof of concept?
So the first thing we're looking at is trying to use this to see if we can effectively reproduce historical clinical trials. So if you take a population of health records, for example, where you have people being given an intervention and people not being given an intervention, and let's say statins for the sake of argument, you can look at the impact of that on their cardiovascular outcomes. You can look over millions of healthcare records and you can estimate all of the individual treatment effects. And effectively, you can summate across all those individual treatment effects to give you what is a clinical trial result. And you can see how well your summary of individual effects relates to the original clinical trials, albeit that the original trials are done in thousands of people, and this can be done in millions of people with the health record data that's available. So that can give additional validation to the approach. But to then take the next step beyond that is to take it forwards into populations that are not well represented in those trials. So for example, elderly populations or populations with much more extensive comorbidities. And that can be done comparatively quickly because you don't have to redo the trial. All of the data is already there in existence. But I think it's perhaps a much more interesting question is, how do you actually then take this forward into practice?
Yeah, that's really what I'm getting at. How do you get from, I mean, you can, all of the things you described sound eminently sensible, but I guess the big question is how you then, as you say, take it into clinical practice. And I guess there are regulatory steps and there are also the practical steps of testing it.
Yeah, but the regulatory steps for applying these sort of algorithms are clearly, there's a whole separate side on that to do with ethics and security. But with regards to the practicalities, from a clinical perspective, the question is whether the data you get from an RCT with very restricted inclusion criteria that's been generated to show a small group mean effect on a couple of thousand people, whether you're happy with that result and to extrapolate that to people that aren't in that cohort, or whether you would be more comfortable with this sort of large data estimate of an individual effect. And is that data sufficient for you to base a clinical decision upon it, given that it would be the same intervention in an appropriate population? But that's
a fascinating debate. I mean, we could really go beyond this forum to debate that in generic sense as well. But let me just come to some of the questions because I'm hogging the floor. So would this work outside of the ICU? I think it would. You already said it would. But I mean, I suppose the question here is, what about when the observations, as in clinical practice, often they're measured inconsistently at stochastic.
That's not a problem.
And so on.
So the inconsistency of measurements is not a problem. What is a bigger problem are hidden confounders. So what that means is that the model assumes it's seeing everything, and that there isn't something hidden from view that actually influences the treatment decision. So it's, do we write everything down, for example, as clinicians? Is everything there in a health record? Well, it's probably not. And there may be hidden confounders that the model would not learn. So there are cracks in its armor that can't, but those can be improved, I think, over time, particularly with the depth and the number of the records that can be processed. So in theory, I think many of those obstacles could be overcome.
So here's a question from Romit Samantha about microbiologists. So won't the training data overrepresent the decisions made during the care of long-term ICU patients who endure serial interventions and bias against patients who died? In other words, isn't it over-prone to survivor attrition bias?
Is it prone to survivor attrition or survivor bias? Well, the thing is that you would still capture those, but their outcomes will be poor. And that is in effect overcome by volume of information, because you are processing such a large training set, and this iteratively and continually improves with the volume of data that's provided to it. So I think, and if you remember that actually the ICU, and relevant to the question about whether this is more applicable in non-ICU settings, ICU is actually arguably one of the hardest contexts to go into because it's so heterogeneous. So I think actually it would be easier in more structured, less heterogeneous contexts. But I think volume of information can overcome the survivor bias.
Okay, and the question from Ken Smith. I mean, how in the brave new world do you think this might be integrated into routine clinical care? Can you envisage a time where actually it would be hardwired into Epic so that it would, prompt you for your decision?
Yes, my biggest worry is that we become lazy.
Right.
You start to do what the computer tells you rather than thinking. So, I mean, for me, one of the biggest dangers of algorithms in clinical medicine is that it stops us thinking properly. So if it leads to that scenario, then I think that's a problem, and that's a hard problem to overcome, because this could be decision support, but shouldn't be decision replacement.
Yeah, which is exactly the next question coming from John Firth. So if this starts to find clinical application, what about the responsibility that we all have for clinical decision making?
I mean, again, that strays into the ethical side of, but it's no different really than any other test, whereby we currently piece together multiple tests to come up with an individualized plan and treatment plan for our patients. This would be another piece in that puzzle, but I think there is a greater risk, as you said, for the previous question, that we could become more reliant upon it. And certainly this wouldn't be a means of divesting ourselves of responsibility for our clinical decisions, or shouldn't
Yeah,
it?
right. Because Alison Slay then asked the question, if your AI decision support tool is contradictory to your clinical judgment, then I guess the clinical judgment should always. Maybe you need to check your.
But it'd be interesting to know why, wouldn't it?
Bias, but yeah, absolutely. Yeah.
Yeah.
And so next question is there a bias towards giving antibiotics to everyone, as the algorithm will generally see antibiotics as a beneficial intervention? Whereas as clinicians, we try and avoid antibiotics if possible due to the concerns and side effects and downsides of resistance and so on. How sophisticated can you get?
So it's a great question. And what you'll notice that I stressed here is that this is a single intervention and a single outcome, and the single outcome is ventilator independence. That's hugely simplistic. And ML approaches often do exactly that. They're geared to answering a problem. What Andy's sort of alluding here is a more sort of generalized form of AI, where actually you're taking into account multiple possible outcomes. That is possible to include, but it's not implemented in this current iteration, but it is something that we've been discussing. The side effects and downsides of intervention aren't well handled by this.
Yeah. So we've still got a role. That's good to know.
Yeah, exactly.
Fabulous questions. Great talk, Owen, and to your team. Please thank them very much. We're bang on time. Thank you everyone very much for coming and for contributing. See you again next week.